big exciting news of the week is that the ENRICH trial finally came out in the New England Journal. We were one of the lead enrolling sites at the University of Buffalo, and so I'm pleased to be one of the co-authors there. And it was a really exciting trial because for the longest time, intracerebral hemorrhage or intraparenchymal hemorrhage has been vexing. The surgical mindset says, well, there's a clot there, there's a mass there that's pushing on the surrounding brain. If I take that out, the patient ought to get better. And yet we had, 4, 5, 6 trials looking at that were all negative. And that was perplexing. There are reasons why we think that, maybe some were negative and why others showed maybe a little bit of signal. But ultimately, this is the first trial that actually showed a benefit for patients from removing the hemorrhage. Now, the way the trial was designed is very interesting, and it addressed some of the underlying problems. Number one, it was looking at 2 different cohorts of patients who had lobar hemorrhages and patients who had basal ganglia hemorrhages. And with the design of the trial, at interim analyses, they looked for futility signal in either one of those groups, and it turns out the deep hemorrhages, the basal ganglia hemorrhages, were evaluated as futile, and so they enriched over to the other lobar hemorrhages. That's number one. So they were finding populations in whom benefit is likely to be there. Now, we'll come back to that. I'm not sure that we've given up on the basal ganglia, but for now, let's concentrate on the lobar. The second part of why I think they were successful was because they took a different approach. As opposed to the typical neurosurgical approach is you take the shortest distance between the surface of the brain and the clot to be able to go in and evacuate it. Sometimes that means you're going through important circuitry. If it's in the language center, the patient can't talk because you did the surgery. If it's in the motor center, they're not moving because you did the surgery. So despite the fact that you've removed the hemorrhage, you've caused collateral damage that is then debilitating to the patient. This took a different approach. Using thin tubular retractors, we're able to go longer distances into the brain through lower priced real estate. And for that matter, let's appreciate where those fibers are using interesting new DTI technologies to be able to map these things out. So that's minimally invasive perivesicular surgery, or MIPS surgery, which was sort of the catchword for this. And the combination of looking at the right set of patients, doing the right procedure, and doing it smartly, I think led to this positive outcome for the trial. Now, getting back to that second cohort, there are other trials that are ongoing looking at, are there certain subsets of that anterior basal ganglia cohort that might benefit still from clot evacuation, and those are continuing to enroll. Maybe we'll find something, maybe we won't. That's why we do the trial. But I think it's an exciting time to be in the field because this is the first time we now have an evidence base for this thing that surgeons want to believe. We want to be able to help the patient, and there was a very robust effect.